Okay, I think we're live. What I wanted to do here was spend the next couple of days breaking up a talk that I initially recorded for the State Emergency Medicine State Symposium by the Sea from the Florida College of Emergency Physicians. That talk is a little bit long and weighty, so I thought it probably makes sense to break this up into some segments. And so overall, what I'm trying to do here is bring both the lens of a frontline emergency medicine physician, both seeing patients with COVID, organizing responses to COVID in the hospital situation setting, and conduct a number of research trials for COVID-19 on one hand, but then also bringing the more critical lens of a medical anthropologist on the other hand to sort of talk about how we got to where we're at, why we're seeing what we see, and who it gets affected by COVID and why. So we'll build up towards that as these smaller talks go on. So each little talk will be about 20 minutes as we go through. I'll come right back to that. So tonight I'm just going to kind of update on the COVID situation in Florida. It's been a little while since I've made one of my bigger posts with epidemiology sort of slides on it. And so we'll spend a little bit of time just going through where we're at right now tonight and for about 20 minutes. And then tomorrow night, we'll get into some issues around kind of public discourse around testing and hydroxychloroquine and conspiracy theory and where these things come from and where we kind of value expertise now in society, and maybe how that contributes to some of this with some of the mixed messaging that we've gotten in the past around COVID. So we'll hit that tomorrow, and that'll lead really well into looking at what I call the mask issue, both the real data we see now around supporting the mask hypothesis that masks decrease transmission of COVID, some of the work that I've done over the summer to really make sure that people wear masks in this area, in Hillsborough County area, because there is no state mandate for a mask or a federal mandate for a mask in this country. Then moving into the school issue, which I recognize is probably hot right now, but we will build to it in the next couple of days, which will give us time to see where this goes. This just came out this afternoon, the Florida Education Association lawsuit, which was looking for an injunction against the governor's ruling through Corcoran that schools had to start by brick and mortar by August 31st. The judge actually granted that injunction this afternoon in favor of the Florida Education Association, which on its own is at least a good sign that democracy still is standing in Florida, and that there is still a judicial branch checking the executive branch. What this means right now, I think, and from a public health standpoint, it's a different story. And there is a school board meeting on August 25th tomorrow morning. I'm sure that more will come out with this. So I'm going to leave this for a couple of days, and we'll get there as we move forward on the fourth of these series. Then the real meat of this, where I'm really kind of rolling into and moving to, is a structural discussion around how racism really structures who gets COVID and how people do when they get COVID, and how this COVID pandemic is hitting a number of other epidemics at the same time, epidemics of class and economics and health. And it's really ripped out and shown bare a lot of vulnerabilities that already existed in terms of state-sanctioned violence, in terms of who gets what kind of jobs, who has access to those types of jobs, money, who's sort of really putting themselves at risk for COVID. We'll get there as we go on and really spend some time talking about how social structures really embody this race concept into people, and how local biology is going to drive these differentiating outcomes. And then I want to spend some time too on these concepts of burnout, physician and workforce issues, and where we might go in the future. What, every large disruptive force can move us to different places. As we get out of those disruptive forces, we may end up somewhere different, and some of those things may actually be better. And so we'll spend some time at the end of this talking about that. Again, this was all recorded for a separate talk for Symposium by the Sea as one big talk, but that was pretty clunky to go through. So this is a broken up talk, and all I'm going to try to cover tonight is just an update on the numbers, because it's been a little while since we've done that, I think, here. So let's get into the numbers. So just as a level set, I look at standardized days. Standardized days here is defined as the first day in the outbreak where the number of cases was more than 1 per 100,000 people in the population. And so that happens at different times in different populations. And what doing this, this approach allows is an apples to apples comparison across different populations. So we can get senses of what the geometry and the pattern of this virus looks like as it moves through a population. Then we can ask underlying questions about that population and try to figure things out and make hypotheses. So going back into the spring now, going back to March of this year, we really saw the outbreak kind of begin in mid-March. Our first case in Hillsborough County was late February, but the outbreak really began in mid-March. And you can see that we went to safer at home and had quite a bit of public health social distancing strategies in place. We did pretty good. Overall, our cases kind of hovered between, 2 to 5 per 100,000 per day. And so that's what's on this y-axis, the number of new cases per day, and it's per 100,000 people in the population. And so we kind of did pretty well, and we did that for a while. We were able to maintain pretty low numbers and a couple sporadic days here and there, but pretty low numbers into mid-June. I'll show you a graph in a second because I think one of the things we want to make sure we do is associate the epidemiology we're seeing with the underlying social decisions, changes, structures, and policies that we are consciously and intentionally deciding on. And so I want to wrap this back to phase 1, phase 2 reopening masks and bars in a few minutes. But just note for now the pattern. And the pattern is that we did pretty well for a while. June came along and we began to see exponential growth. And what I mean by exponential is, if it's linear growth, you might expect maybe 1 or 2 per 100,000 increases per day. But instead, what we really get in mid-June is a doubling of that rate, and then another doubling of that rate, and then another doubling of that rate, right? So really fast exponential spread or increase, so much so that by the late June period, June 27th, we actually break New York City's record for the number of new cases in one day. We hit that 79 per 100,000 mark. So pretty significant growth happening during that period of time in the Tampa Bay area. And so our hot spot or our peak, and this looks like it probably was the peak, probably around June 27th. But this peak period running from late June 27th or so to mid-July is kind of our peak period. Keep that in mind because as we go through this talk or these talks, this series of talks, this period of time is really when we're having to make decisions about, do we send our kids back to school? Do we reopen other businesses or other places during a period of time where we are exponentially in a whole different y-axis, basically, of scale of where we were just a month previous to that. And so as June rolls along, we do start to see a decrease in the number of cases. And if you look right now, over the last 2 or 3 weeks, we've actually really shown a pretty steady and maintained a decrease. And so the question right now, I think, is, are we flat right here at around the 15 to 20 per 100,000 case area, or we continue to decline? We've hit a number of times we've hit spots where we've stayed flat. And sometimes you get flat because the social distancing measures you've employed have done all they can do. And you have to do something else to get lower. And so the concern as we talk through this is, if we're flat, then how do you get to that next step, especially in light of maybe schools reopening, fall coming with other viruses right on their heels. So that'll be one of the questions we go through overall. But in general, this is a pretty promising appearance of where we're heading right now with the virus, that we have overall trended down. Same basic numbers here, just an exponential increase in growth in virus, peaking at 79 per 100,000 cases per day, and then starting to see a decrease right now, hanging around the 15 per 100,000 case per day mark. As a matter of fact, if you go back to March, we were at about 1.5 new cases per 100,000 people in the population per day. And we really saw pretty linear growth. If you look in the spring, March, April, May, right, 0.5 per month. That's a linear growth rate for those 3 months. And so I divide the virus into probably 3 phases now. Phase 1 is this linear growth phase of pretty controlled growth. doing a pretty good job from the public health strategies to limit spread and limit transmission. And so we'll talk as we go through this what that means. The other side of that coin, right? Limiting spread and limiting transmission, of course, means other things like closing schools, closing bars, and causing significant economic disruption, especially to certain parts of our population. So we'll talk through that as we get there. But notice though, we've done a pretty good job in those spring months, and then boom, June comes and the world changes, right? So in June, we increased the new cases per 100,000 by a 10-fold magnitude. So we see from May to June, a 10 times increase in number of new cases. And then another exponential growth from June to July, we double the number of new cases per 100,000 per day. And this is significant because during July, again, is when we're making lots and lots of important policy decisions about schools and about our area's economy and how we want to handle the future. We're doing this at a time where things look vastly different than they did in the spring. And then what's very promising is that I think a lot of these social strategies have worked, and social mitigation strategies have worked, and we're starting to see for the first time actually in this outbreak locally, we've seen a decline in the number of cases month over month from July to August. We're back down to about 20.5 right now is the rolling August average for new cases per 100,000 per day. So very promising that instead of seeing another increase, we've actually seen a decrease here. What does that mean? We'll talk through as we go through these talks, and how do we get there is part of what we're going to talk about as well. And we'll get to talking about some of the controversies around data, and can you trust the data? Is the data real? And I'll talk a lot about that tomorrow, but suffice it to say for now is that the data triangulates pretty well. So working, in a busy emergency department with a lot of COVID patients, we have definitely seen a decrease both at my facility, but also across the Hillsborough County area and entire Tampa Bay area, the number of people who are being admitted per day with COVID to the hospitals. Again, peaking, really in July, late June, early July, with 60, or so admissions per day, and then starting to come down now. And then back in August, we are, probably back to where we were in May with about 20 admissions across the county per day. And mimicking that, again, is the people who present to the ER with COVID-like illnesses, meaning fevers, cough, other significant sounding risks, equivalents to COVID positivity. We've seen a peak and now a decline in that population as well. And so I show this because it's important to understand that you can find different ways to trust your data. So even if you are unsure about one source, what does the other source look like? And can you triangulate that data and make sure everything's telling the same story? And here, everything is kind of pointing the same story. We had a peak in early July. It kind of was high numbers through most of July. Then around the end of July, we started to come down. We have come down. We have a little bit maybe of a sort of a flat plateau right now. And it's a question as to whether we can come down again and continue that downward slide, which we should be able to because the positivity numbers are also coming down as well. And they're coming down pretty consistently week after week. So where we are right now is that we have enough data after 6 months. We've been in this virus for 6 months, transmission of this outbreak for 6 months. And so where we are right now is we have enough data to know that both dialing it up and dialing it back does work. We know that different mitigation strategies are useful. If you remember that number called R0 is the reproductive rate of the virus. It's how many people one person with virus will give that virus to. And R0 is not just a static epidemiological number. It's got a lot of social life to it. And what I mean by that is the other constant, or the other variable in the calculation of R0 is beta, and beta has a lot of the social distancing measures kind of built into it. And so R0 changes. If you're not doing anything, the R0 is probably around 2.5 to 3 for COVID. But if I'm doing a lot of stuff, I can drop that R0 pretty low. And so R0 is not a static number. We're going to come back to that when we talk about red herrings of data and and where we are with like herd immunity and those types of concepts. But R naught moves around. It moves around based on how good of a job we do of implementing these different strategies, which we know do work. And we have enough data now across not only, our area over months, but, geographically case control or case comparison data has essentially been naturally built in by different states doing different things and different countries doing different things. And so we know different mitigation strategies have different impacts on R naught. And of course, the goal is to bring it as under 1 as much as possible. And so we know that if left alone, unmitigated with the R naught up to 2.5 or 3, this virus would do massive damage across the globe. If we do some things, we start to do some social distancing, we can actually decrease by about half that amount of damage on a death this virus would have caused. If we enhance that, we do this early, we don't hesitate to roll back, then we can even save, probably 20% more lives. And then the more aggressive we are about triggers, and this becomes a really important question as we move into the fall. What triggers do we have? This is an important question we had schools too, because where we were really moving with school reopenings was moving from a static date-based school reopening to a dynamic data-based school reopening, meaning let's have some triggers in mind where certain actions occur if those triggers are met. And it's clear from the epidemiological modeling data that the more aggressive those triggers are, the more lives you can save. And so the goal from a public health standpoint would be to build triggers in as we move forward, so we make sure we know when to dial it up and dial it back. And that's probably the game we're going to have to play until a vaccine. And we'll talk more about why it's until a vaccine as we go through these next few nights. So to make it clear that social strategies, that viral mitigation strategies do work, this is just that epidemiology growth curve for our area in Hillsborough County, and some of the major social mitigation strategies that we've employed and invoked to decrease virus transmission. So again, going back to the first point of time where virus was more than 1 per 100,000 new cases per day in this area, about March 18th. A few days after that, about 10 days after that, we started the safer at home strategy in Tampa. So we're looking at this turquoise line. We're able to keep things pretty flat. Florida started a safer at home a few days later on April 1st. And so we're staying pretty flat. And then the first phase of reopening occurred on May 4th. So about 48 days into the outbreak. Now, if you zoom in on here and you look at the slope really closely, there is some debate around whether or not we were really ready for phase 1 reopening. Having said that, in hindsight, looking at the data, it looks like we actually did pretty well post phase 1 reopening. The numbers stayed pretty low post phase 1. So this is what hindsight allows us to kind of look back at and talk about. Anytime we make a change of either dialing it up or pulling it back, anytime we put a new strategy in place, it'll probably take about 2 to 3 weeks for that to lag in the data and then catch up. The incubation period of the virus is about 2 weeks at longest. So it takes a little time. Plus it takes some lead time for people to buy into the new strategy. So most of these new laws, when they pass, take a few weeks to start to go active. And then once they do go active, people have to buy into them, and then they actually have to have a biological time for effect. And so here we have, basically 32 days to see what happened, and nothing really happens. We stay pretty good. Now, there is a debate again about the fact that we went to phase 2, when you can see if you zoom in here, this turquoise line is actually on a little bit of a slope up. And so whether we should have gone to phase 2 at day 80 or not is definitively open up for debate, I think, right now. And I think the data speaks for itself, is that phase 2 reopening, which includes bars reopening and larger crowds gathering and more social events, the effects of that were pretty damaging. And so if you look at phase 2 reopening, that's where we really start to see that exponential climb, rapid climb up from about day 80 to about day 101, where we break the record for number of new cases per day in the United States, breaking New York City's record of 74 per 100,000, getting to 79 per 100,000. This orange line is Dade City that I'm tracking with it. I put that there for a couple of reasons. One is because way back here on day 10, 15, 20 of our outbreak, Dade City seemed like a whole different world to us, right? If you look over here, Dade City on day 15 had about just call it 20, just around, had about 20 per 100,000 cases, and we had about 2. So they're at magnitude about 10 times worse than we were. So it seemed like a whole different world. If you were just graphing just this, you could barely put them on the same y-axis. But now fast forward, we start to kind of just, track right along with Miami-Dade area. And then Miami-Dade ends up in places that we couldn't have even imagined, in even worse places than we were. Fortunately, they are starting to come down a little bit as well, but they really broke the record for peaks, so close to 140 per 100,000 new cases per day. So double what New York City saw. So really poor conditions there in Miami-Dade County. Also left them in phase 1 reopening, which made them immune to some of the emergency orders about school reopening. We'll get to that when we talk about school reopening in a couple of days. Recognize that we are an exponential increase up. Some things started to happen in this area of time. This is when the conversation around masks became very intense, eventually leading to a mask mandate on June 24th, recognizing that we probably still need to do some more, that masks aren't everything. Masks do help, but they're not, right? Every strategy has a little effect on R-naught, but it's not going to take R-naught to 0. So the big thing, of course, was bars. And so bars also were rolled back on June 26th. Whether people were really following those bar closures is a different story we'll talk about. But through early July, at least, the enforcement of those bar closures increased. And what we start to see a few weeks later after mask ordinance passes and bar ordinance passes, we start to see stabilization, right? We stop climbing, we stabilize for a couple of weeks, and then post-mask ordinance, post-bar ordinance, we started to climb down now. And so now we're in a downward trend overall. The question is going to be, as we go on, how do we sustain that downward trend? Just to give a reminder about how I've looked at this data, Balaji and Sitha and Dave Ween and I and Jared, my resident, who's done a great job putting all this data in for Hillsborough County, we've used this nearest neighbor model where we recognized early that other populations that were ahead of us in time in the outbreak, they had hit a 1 per 100,000 before we did, and were some number of days ahead of us. We could take a look in those places and get a sense of where we might be going, and then test hypotheses under this to see if we could come off of that curve. And so way back in March, we recognized that we were kind of tracking right along that Italy curve. And that was concerning because this red line for the US was tracking right along this blue line for Italy. And so if we would have gotten to day 15 and stayed on the Italy curve, we'd have had about 22 per 100,000 cases. And we only had 2 per 100,000 cases back here. That seemed concerning. Now, of course, the whole world's changed. And if we would have peaked at 22 per 100,000 cases, we'd been in really good shape. But that's not the way it shook out. So just to kind of get a sense of what we did with this kind of data, this allowed us to make predictions in a hospital setting and a resource utilization setting, and also to kind of see how we were doing. Was the stuff we were doing working? And so to give an example of that, if you think about Safer at Home being implemented right down here around day 0 or so of this graph, start to see some mitigation strategies. Day 10, the full Safer at Home, you start to see us fall off that curve of Italy about 2 weeks later. So pretty good evidence. It's at least correlation that, about 2 to 3 weeks after some significant public health strategies was implemented, you do fall off of that Italy curve and see some positive change. And so Hillsborough County fell off that Italy curve and really never came back on it until June. And then in June, the whole world changed again. Talked about that. So this is just a zoomed in view of what I was just showing you. So we were tracking the Italy curve for a while. We started some social distancing strategies. About 3 weeks after those, we were able to say, yes, those are working because we changed our slope. We changed position off that Italy curve. We fell off, we flattened out. So that's good. Now, the concern, of course, is that way back then, we would look at the New York City curve and say, holy crap, that is a whole nother world up in New York City. New York City looked, 100 times worse than we did at the time. And New York City looked, at least 50 times, at least 10 times or 8 times worse than Italy. So it seemed like a whole different world. So we were tracking the Italy curve. We fell off the Italy curve. We were below the Italy curve. We were kind of down here somewhere. And New York City seemed like a pipe dream, a place we did not want to go. Of course, we know what actually happened was that when we got to about 450 per 100,000 cases in our area around June 22nd, I kind of recognized that the days after that, June 22nd, June 23rd, June 24th, our slope was starting to look a lot like how New York slope looked back in mid-March. This is that nearest neighbor idea. So in other words, if you go back to about March 25th, when New York City hit 400,000 per 100,000, 400 per 100,000 cases, and compare that to June 22nd, we hit 400 to 100,000 cases. After that, our slopes really mimicked each other. And I predicted back then on June 22nd that by August 3rd, we'd be hitting 2,000 per 100,000. Thousand cases, which is a cap. This is per capita, right? So we surpassed the per capita New York City numbers. So fortunately, we do have our mask mandate and our safer at home, our mask mandate, our bar orders that kind of go into place right here, and we start to see some flattening of our curve taking place. So New York City actually had their mask mandate and their safer at home happen back here somewhere, and so we knew it would take longer for us to flatten that curve than it did for New York City. So we're just now starting to flatten out. And it looks like we'll probably flatten out around the 2,700 per 100,000 case range, which is, just going back to, again, the end of May or early June, unthinkable. We would have thought we were going to be at the 250 per 100,000 case range. Just a zoomed up view of this, again, for the first 100 days of the outbreak or 80 days of the outbreak, we're like totally different looking than New York City. New York City is way up here. We're way down here. It doesn't even look like the same world. And then we see this exponential climb, and then we see ourselves surpass New York City. And, hopefully we'll start to plateau now around that 2,700 per 100,000 case mark. And so just to kind of give a better idea of what I mean by all this slope stuff, if you look at the turquoise line starting at day 100, and look at the turquoise line to here, this segment of the turquoise line looks just like this segment of the pink line over here. So in other words, we were climbing at that same rate that they were climbing back then. So that was the concern we had. And unfortunately, we met that concern. We got to the place we didn't want to go. Fortunately, our case fatality rate stayed very low. So how did our case fatality rate stay low in spite of the fact that we climbed up to where New York City was? Well, a couple of things. We had the benefit of time, right? So we had that lag time where we were able to build in systems and infrastructure. So in Hillsborough County and Pinellas County, for example, we have a shared dashboard that allows all 50 something hospitals in this entire 4-county area to share resources with each other. That's something New York City not have. Medical care has improved some since then, right? We know not to intubate people early and waste our ventilators. We know to put people on high flow nasal cannula oxygen. We know that everybody doesn't have to stay in the hospital and some people can go home. We have dexamethasone as a treatment. We use some convalescent plasma. We have a number of research studies stood up now. So we have a number of ways to help these people. And then I'll argue as we go on too, population structure may have something to do with this. Life histories may have something to do with this as well. So why one area may look different than another area. This is a great, this figure right here is asking itself to be tested by somebody who's interested in life history theory or population structure theory to ask if that explains some of these differences in case fatality rates versus the alternative hypothesis, which I think is probably more right, but they should be tested, is that just surge capacity, the quicker you surge past your capacity changes things. Sweden's different. Sweden basically ignored the fact that people were dying and just sort of wrote it out. So that's a different thing we might talk about as we go on, but that's a different ballgame. Italy really looks like a surge capacity problem. High dense place overruns capacity very quickly early in the outbreak before people know the medicine and just overruns things and you have a lot of deaths. Okay, that is it for tonight. So I'm going to stop there. That's an update on the numbers. That's where we're at right now. And then what I'm going to try to do tomorrow is give an update on where we are with testing and then some of the what I call magical thinking and conspiracies that are living out there right now. Okay, so hope you can check back in again and hope this was useful. Thanks.